Good afternoon, everybody. It's a pleasure to be back here with another episode of Epidemic Watch lecture series. And today we have a very eminent speaker, Dr. Zinia Nujum. She's an additional professor at the Government Medical College in Kollam. And Dr. Zinia has quite some great accomplishments on her side with her research interests spanning neglected tropical diseases, very specifically dengue, rabies. And she has received the WHO Special Program for Research and Training in Tropical Diseases, postgraduate training grants in the implementation research in 2014, Special Appreciation Award for Research in Dengue from IMA Kerala in 2019, and Dr. N.R. Roy Award from the Indian Public Health Association in 2021. And she's also quite active internationally. She's also the global assessor for the Royal Society of Tropical Medicine and Hygiene, London, and the national assessor for effective vaccine management for the National Institute of Health and Family Welfare. She's a member of several state-level committees, including the Kerala State Planning Board, Working Group on Medicine and Public Health, and the State's Rapid Response Team and HIV State Central Surveillance Team. So today, she will be talking to us about strengthening surveillance and research for dengue to enable prevention and control, the need of the hour. The stage is all yours, madam.
Shall I start?
Yes, madam.
Thank you very much, Dr. Vinod, for this opportunity. And are there all the participants? Can I just have a look at the... But here, I think we have just 2 participants. Should we wait some more time?
No, madam. The participants are live, so they will be able
Okay.
to see you and hear you.
Okay. So you have started the recording also, so you can start. Okay, so the topic is strengthening surveillance and research for dengue to enable prevention and control the needs of the hour. So acknowledgements to Dr. Vinod and Dr. Bindu PS, my professor and head, Dr. Anish GS, who has shared with me some of the results of the study of WHO Trivandrum, and Dr. Sri Lakshmi. She is working with the National Institute of Virology as a scientist. So what is basically surveillance? There are several definitions of surveillance, but the definition which I like to project or often talk of is that it is the continuous scrutiny over the factors that determine the occurrence and spread of disease. So if you look at surveillance in that context, the objective of surveillance is actually prevention. It is primary prevention of any disease. And the outcome would be the reduction of burden of disease. So what we generally talk of with surveillance, or what we generally do, is just look at the burden of the disease. And we forget to actually look at the factors which determine the occurrence and spread of disease. Rather, we should be using the burden of disease as a benchmark, and also to evaluate the effectiveness of our surveillance or our control measures. So today I will talk about what we could do on the different aspects of surveillance. And as a whole, I would call that as epidemiological surveillance, which includes the surveillance of the disease burden, the viral surveillance, the clinical surveillance, entomological surveillance, and surveillance over the control measures, environmental surveillance, and some points that we could do or look at related to the vaccine. So this is from the WHO document on the dengue serosurveillance, the methodology, the design of dengue serosurveillance, which talks about the predictors of dengue incidence and seroprevalence. So these are some of the things which you already know of, but just prevalence rather than focusing on the disease burden, we should be looking at the factors. I just put it there. And in that, I did not see this water storage practices, which I thought was, again, a very important risk factor or a factor to be looked at least in some areas. So let's first look at what we should do, or what some of the thoughts on improving the surveillance of the disease burden. So when we think about the disease burden, you usually have the surveillance from the Health Services Department or from the IDSP, that is the Integrated Disease Surveillance Program. And what is reported is only the tip of the iceberg. And the burden, so we get from this reporting, where I would like to say that the denominator is important, because usually when we talk about the reported dengue, what we talk of is the number of cases of dengue and the number of deaths. And we generally tend to compare across the states and the districts with just looking at the numbers, where the population across the states and the districts will be different. So in fact, that is not a very difficult task to look at what is the population. It is better for us to state those reports per 1,000 population, or according to what is the numbers. So we need to look at the denominators, which is important. And then we have estimations. We also have zero prevalence surveys, and these are the three types of data that we can look at when we look at the burden of the disease. There is a need for age stratified seroprevalence, and also looking at local specific seroprevalence. Then we just look at whether it would be useful for us to use case definitions for surveillance. Then another way of looking at or arriving at the burden of disease would be the combining the data from sentinel surveillance and fever surveillance. We do have fever surveillance in the routine IDSP. And we also have sentinel surveillance labs. We have over 500 sentinel surveillance labs throughout India. And I think around 39 sentinel surveillance labs are there in the state of Kerala. So likewise, it would be operated in all other states also. So how would we use that data? And that last point on the disease burden would be like using the morbidity statistics alone, actually, to prioritize action that could be misleading. So we could combine the morbidity, the incidents of the reported cases along with the mortality and calculate the disability adjusted life years to look into the burden of dengue. So this is what we already said, and this is something we have often seen, that we have a large number of asymptomatic dengue infection. What we see as dengue fever or severe dengue is only the tip of the iceberg. So there is the dengue situation in India. You can have a look at the this is from 2017 to 2022. So as I told earlier, we have what is there. This is there in the NVBDCP website. And we can see that these are just the numbers. So if you look at Kerala, you can just see that around close to 20,000 cases we had in the year 2017. Before we have this outbreak this year, this might have been the highest number ever reported. And so these are only in terms of numbers. So looking at this, we may not be actually able to compare and prioritize across. So it's a very easy task for us to get the state population and compare with the denominators. So this is one thing that I'd like to suggest. I actually wanted to do and show, but because I couldn't do that, probably one of you among the audience could take a task of looking at that. So for the year 2022, we can see throughout India, we have over 2 lakh cases and 303 deaths. So that's about the dengue situation. I hope the slide has come back. So 2017, just look at the year 2017, because I have taken 2017 because the estimation that I could get for India was for the year 2017. So the reported cases is close to 2 lakh, but the estimated figures we have around 13 million. So this is the importance of estimation. You could get the real burden, estimated number of dengue individuals in 5 to 45 years of age. That is around 13 million. And then this is a much higher estimation, but that was done earlier. It was in the year 2010. Most of us must have seen the article by Vatas et al. Published in Nature, and according to which India has the estimation is 34 million. and India contributes very high to the global burden of dengue. Whereas the same year, in the 2010, the reported cases were only 12,484. So we need all these, we need these estimations based on modelings. And we can see in this picture, India contributes 34% of the global burden. And this is another way of looking at the burden. We could do seroprevalence studies. And this is the first one is a systematic review and meta-analysis of dengue seroprevalence in India. And that puts the figure at 56.9%. We also have a nationally representative cross-sectional study by Murekas, and that's in 2017, and which puts the seroprevalence at 14.7. So that is about India. That we've just mentioned all those things. And another thing is, now we will be talking about it later, how we could use the febrile illness, the fever surveillance. So as per this reference, you can see that 1/4 of the acute febrile illness is actually dengue fever. And in Kerala, we had the first case in 1997. 2003, we had first epidemic, and Kerala is now hyper-endemic for dengue with multiple serotypes. So if you look at the Kerala data from 2011 to 23, I just put the cases there and the deaths. You can see that in 2017, we have a huge number of reported cases. So wherein the actual burden would have been much, much higher. And again, now in 2023, again, we are close to 20,000. That is including the suspect and the confirmed cases. And if you look at the position of dengue in Kerala over the years, you see several years, most of the years it is the top number of cases is dengue among the communicable disease. But some of the years we can see it is hepatitis A and chickenpox. Even this year, you can just look at this is it's not coming up. If you look at you can go to the website of the DHS and you can see the IDSP data, and you would see that there are a huge number of chickenpox cases, which I don't know why we have to look into that. And most of the years, it has been Trivandrum districts that reports the maximum number of cases of dengue. So with regard to that is the reported cases in Kerala. With regard to the estimations, I didn't get much of literature, but we have a seroprevalence, a very good study, which was done by the Trivandrum Community Medicine Department and the government of Kerala from the WHO funding. So that is among children in the age group of 9 to 12 years. And there, the seroprevalence was 29%. So you could, and they validated this seroprevalence. The seroprevalence was estimated or was obtained using the indirect ELISA method. And then they validated it with PRNT. And that is what the WHO says as the method to be done. And so the validity corrected prevalence was 31, nearly 31%. So that's less than the overall prevalence of India. And that was done in 3 districts, Trivandrum, Kozhikode, and Kollam. And the highest prevalence was seroprevalence, again, as expected in Trivandrum. So this is another small study, which was my PhD work in pregnant women. And actually, it was a cohort which was looked at the incidence and outcomes of dengue. I haven't put the full details. We have time, we may discuss during the discussion. So since we are talking about seroprevalence, at the baseline, we in 1/3 of the in the cohort, we looked at the IgG and in 490 samples, and there again the prevalence was 30.4. So pregnant women perhaps should, compared to this age group of 9 to 12 years, they should have a higher prevalence. Perhaps the differences in the methodology. There again, I use the IgG, the indirect ELISA method. So somehow these two figures tally. And the estimated force of infection in this Trivandrum study, that was 3.3 per 100% years, and seroconversion rate was 4.8 per 100% years, which is again similar to what I got in the pregnant women after the follow-up over the pregnancy period, and we looked at how many had seroconverted in a subsample, and that is how we obtained this. So we find that there are large number of inapparent dengue, and these are some of the references which talk about that you could get around 65 to 90% of infections could be asymptomatic, and this is again from the Buttertag study, where they put the ratio close to 4. And different studies give different ratios, and as high as 282 has been reported from different studies. So the point is, like, if you want to consider vaccination, we need AIDS stratified serosurvey. So we need at least one recent AIDS stratified serosurvey in a geographically relevant location. And the routine available data, the data from the IDSP or the reports that could be used to predict the local serosurvey. So you can have a prediction of what is the local seroprevalence, and using that, actually you can stratify the places to low. I'll show that in the subsequent slide. So this is about the reported seroprevalence in Kerala compared to other endemic countries. Actually, it is lower, and this is considered to be low to moderate. And there's another study from India. So India, the annual force of infection is 11.9%, which is higher than this 3 to 5% per annum. So this was another point that we had discussed in the beginning, that we need age stratified seroprevalence. So if you look at the nationally representative study, so they have put up the seroprevalence in the different age groups. So you can see that from 5 years, then to 9 to 17 years, 80 to 45 years, there is an increase in the seroprevalence. So this is again the age specific seroprevalence from the Trivandrum study, that is similar somewhat, like you got it, but it's slightly lesser actually. At 9 years, 25.7, at so the 29.5, 30.9, whatever. See, what we want this age stratified seroprevalence data, because now we know that we have a vaccine, it's the dengue vaccine, which is licensed in some countries, and the WHO says that it is indicated in places where the seroprevalence is 70% and higher by the age of 9 years of age. So the target age group for that vaccination is 9 to 45 years. So you can introduce the vaccine only if you have a seroprevalence of 70% by the age of 9 years. So if it is 50 to 70% the seroprevalence, then you may use it. If it's less than 50%, it's not recommended. So this, because it is the performance of this vaccine is dependent on the seroprevalence or the immunity that the community has acquired. Okay, so in 2018, the WHO has recommended a pre-vaccination screening strategy before giving the vaccine. So only those who are seropositive will be actually administered the vaccine. So this is why we now need the age stratified seroprevalence. So these are the age groups in which we need to do the serosurvey as per the WHO. So the target age group is 9 to 12 years, and that is critical, and that is what will give us the information to decide on the vaccination policy. But even in 5 to 8 years, it is recommended if the it is most valuable in areas with epidemic dengue transmission, that is non-endemic. And above the age of 12 years, it is optional, but we definitely need to do with the age group of 9 to 12 years. So that again, when we do the seroprevalence, we have to stratify the places according to the, as we said earlier, the predicted seroprevalence based on the reporting. So we could classify them as high, middle, and low. And if you're planning to launch the vaccine nationally, we need this sero survey to be done in all the 3 strata. And if it's the targeted vaccination, perhaps we have the option of just looking at 2 strata. And it's also important for us to understand the local dengue epidemiology, which means that you may know the state seroprevalence, you may know the district seroprevalence, but you have to break that down to administrative units, smaller units, because the epidemiology of dengue is heterogeneous because the small spacious places. So that is what the WHO says as administrative units. And a larger administrative unit would be definitely easier for us, but because of the heterogeneity, we need to look at smaller administrative units like the municipality. So in a place, you could have an area which is at high altitude where there's no mosquito, and at the same time, you could have a low altitude place with endemic dengue. So that would bring in the heterogeneity of the prevalence and the disease epidemiology. So you have to actually initially identify the predicted dengue incidence based on the data that is available, classify areas as highest, middle, and lowest burden, and then do the seroprevalence study across the different ages. So we would get the predicted dengue burden that you could look at the data. You can take the age stratified cumulative incidence of the past 5 years. And in order to, if you don't really know which is a high burden place, you can look at the mean age of dengue. And what they say is the units with the lowest mean age can be assigned to have the highest burden. So in this Trivandrum study, their overall seroprevalence we said was around 30%, but there were clusters where the seroprevalence was 70%. That would the percentage that qualifies for the vaccination. So it is important for us to look at this heterogeneity. Perhaps when we are thinking of introducing a vaccine, we may think of introducing the vaccine at the subnational level. And we do have examples of subnationally introduced vaccines like the Japanese encephalitis. So that is about the burden in terms of what we have, the reported burden, we have the estimations, we have seroprevalence surveys being conducted, and also talked about the need for an age-specified, age-stratified seroprevalence. Now, this is the, you could also use case definitions like we know that the WHO has over several years, right from 1997, several revised definitions that has been put forward by the WHO. And if you have a probable case definition and your surveillance system is able to pick up what is the number of probable cases of dengue, then perhaps we could estimate or we could find what is the real burden of the illness. Now, this is a small study that we again did, that we had 851 participants. And we looked at the sensitivity, specificity, and the predictive values and all of the WHO case definitions. That was the 2009 and 2011 case definitions were compared. And the performance of the 2009 case definition was considered to be better than the 2011 case definition, using the, like when we looked at a single indicator like the diagnostic odds ratio. So, but when we use the case definitions, it's very labor intensive to look at this case definitions and see what is the magnitude of the problem. And it is also limited by the low specificity and the non-uniformity in the case definition. Sometimes we see that WHO has a case definition, IDSP has a slightly different case definition, and the reporting standards that may also vary. So it's they're very difficult. Like it may not be very easy for us to use it, but still we could. And so there is another way that we could look at to find the burden of the dengue would be if we have an effective fever surveillance mechanism, and we have parallelly the sentinel surveillance. In those sentinel surveillance lab, we would be testing those fever cases for dengue and other illnesses. So you know that this percentage of your fever cases are dengue, and if you know the magnitude of the fever, perhaps we could extrapolate to that to get an approximate idea of the burden of the illness. So this is a study that we did to find out estimate the burden using active dengue sentinel surveillance. It was not like the sentinel surveillance was not that of the state, but what we actually did in the primary, secondary, and tertiary setting. And we used the fever surveillance data from the health services to try to extrapolate. And then what the several findings of that, what we found that only 1 to 10% of those estimated cases are actually being reported by the state. So we could actually use this and project the caseload. Now, another point I'd like to make is that we were so far talking about the disease burden in terms of the reported figures, the estimations, the seroprevalence, trying to estimate from the fever surveillance and from using the WHO case definitions. All of it is about the morbidity of the illness. But when we talk about even the seroprevalence, what we are capturing is just a cross-section of people, and those people who have actually died, we may be missing them. So we need to actually pool the experience of morbidity and mortality to arrive at the actual burden of illness. So at least once in a year, it is possible for us to actually calculate the disability adjusted life years. That is a summary measure that is widely used, and it is a sum of years of life lived with disability and years of life lost due to premature deaths. And we do have the dengue DALI available globally and for the country. So we made an attempt, a small attempt to look at the DALI for Kerala. I'm not going to talk about that. It's available. It's a published article. But what the point I want to make is, this is the dengue cases and the incidents. This is we do put based on the reported case also, and based on estimations also, we have the rank of the different districts. Now you can see that which district has got the highest rank or the maximum number of cases reported is Trivandrum district. We also classified the districts based on the burden, and that Trivandrum is number 1. So the same year, if you look at the mortality experience, if you look at the ranking of mortality, number 1 is Kasaragod and number 2 is Thrissur. So if you look at DALI, this is the first figure. The first figure shows the DALI. This is the incidence, and this is the deaths. So we would see that the DALI is. I think I missed one slide. Okay, this is the DALI. Here you can see the DALI. This is the mortality ranking. You can see Kasaragod is number 1, and you have Thrissur as number 2. Trivandrum has got a lower mortality. So if you look at the relative DALI rank category, you will see that Thrissur is actually ranked number 1. So the contribution to DALI by mortality is much higher. Again, there are some other interesting findings, all of which I'm not remembering now, but generally we see that the dengue is higher in males, but when you look at DALI, it is higher in females. Probably it also accounts for the life expectancy, severity, all these things come in. So it's good for us to combine multiple indicators to look at the burden of illness so that we can prioritize correctly. Otherwise, we may go wrong. I'm just using this example to tell that this is again the same thing in a snapshot for 2014 and 2015. So for 2015, we did not find much of a difference because the incidents, the districts have had similar, they're similar in terms of district, that is the incidence and mortality. Okay, so with that, I think we finished the first part of the presentation is on the surveillance of the dengue disease burden using the reported figures, the estimations, the seroprevalence studies, need for AIDS specified seroprevalence specifically in the context of introducing a vaccine. And then we just looked at why we should combine the mortality experience with the morbidity to categorize the burden. That was what, and the use of case definitions and sentinel surveillance and fever surveillance. Okay, now we'll just have a snapshot of the requirement or the need for virological surveillance. We know that this dengue virus is evolving, and I know that there are people like Vinod sir will be able to talk much more about this part of it, but I'll just go through. So just to remind you that this is a flavivirus and it is an RNA virus. And we have 3 structural proteins, CME, and 7 non-structural proteins, and we have 4 serotypes. So that's again the slide to show you that we have the structural proteins and the non-structural proteins. With the 2, we have A and B, and 4, we have A and B. That's how we have 7 non-structural proteins. So this is a review of the global epidemiology of dengue outbreaks from 1990 to 2015. And you can see how the serotypes of the dengue virus has been evolving over the years. So from 1990 to 94, we see that DEN2 is most frequent, 83% of outbreaks. 95 to 99, we see that this 55% is DEN2. Again, 2000 to 2004, it is 22%. But then from 2005, we see the co-infection dominated outbreaks that constitutes 52%. And of that, we have 17% of them with all 4 serotypes. After 2010, we see that then among the mono-infection outbreaks, so this outbreaks you could classify as caused by a single serotype, or you could have multiple serotypes coming in. So the monotypic outbreaks that was dominated by DEN1, and the co-infection with all 4 serotypes continue to dominate the co-infection outbreaks. So the different serotypes that were predominant in different WHO regions. So you have 1 and 2 in African American region, European region, you have DEN1. Other sides are after 2010, then 2 and 3 in Eastern Mediterranean region, and then 1 in Western Pacific region. So this is just the map to show you that 1990 and 94, if you look at India, it's white here, and you can see, so for those of you who are like me and who would like to get reminded of the map, you can see that it's Brazil, Australia here. And that we have then 1, 2, and then you have Australia with the then 2, and you have some of these Malaysia, Philippines, all those Western Pacific regions with then 1, 2, and 3, where at that time we didn't have the outbreak. And then in 95, 99, I think Kerala had the first outbreak in 97, and here we can see that it is 1 and 2 that is in the picture there, and slowly we have all the 4 serotypes by 2000. In this period, you have all the 4 serotypes here, and close by we had China. China again, we see that it was DEN3 there, but now you have all the 4 serotypes in China, and also some of these Western Pacific region, we have all the four serotypes. And 2005, and again, there is a changing epidemiology. We see that there is then one here, but again, we have all the four serotypes. So this is something that we need to keep an eye on, as we all know that the serotype is something which determines one of the factors which determine the severity of the disease. So, what we know is that DEN2 is associated with the highest risk of VHF, and that is followed by DEN3, 4, and 1. And within the serotypes, we can have different genotypes. And DEN2, there are 5 genotypes. That is the American, Cosmopolitan, Asian, Southeast Asian, and Sylvatic genotypes. And why we need to know about the genotypes? Because like, for example, the introduction of an Asian genotype of DEN2 in Vietnam, from Vietnam into Cuba in 1981, its subsequent spread to Americas was followed by a major outbreak of THF. So the severity of could also be associated with the genotype. And this American genotype not associated with severe dengue, Asian genotype virus, they also displayed more efficient infection and dissemination. So similar to what we talk about with COVID, not only just the severity, but the infection, the dissemination, the transmission, all this could be different with different genotypes. So that's why we should know about the genotypes. And coming to some of the studies I could look at, which have characterized the serotypes. So this is one of the earlier studies in 2008 done in Ernakulam, and that showed then 1, 2, and 3. And then the recent studies we have from Trivandrum, that is again the WHO Trivandrum study. Before that, that is in 1920, but then before this study is actually have the data for 2017. It says that in 2017, then 1, along with it combinations, around 60%, it was the predominant serotype, followed by then 2. And by 2019, there is a marked increase in the proportion of then 4 cases. That's what the study says. And then 3 infections more likely to present with warning signs. So that is the importance of understanding it. But this is what the study says. And in this study, they had looked at the 52 samples, and in that the predominant serotype was again then 2, it's 73%. So this keeps changing, and it is important for us to have a surveillance of what are these serotypes, the genotypes, and this is again a summary of what I have just presented. And but the global, the systematic review, which was done on around 262 outbreaks. That this is again showing that 21% is this monotypic of DEN2. And in Kerala, we just saw what is there. And this is another study from UP again, which shows that DEN2 is the predominant serotype. So some studies which I could get. So we all of us again know that besides these serotypes, we also have in this 5th serotype, which has come in and in 2013, and that is actually reported in 2013, but it was from a 37-year-old farmer in Malaysia in the year 2007, and only 1 case was admitted, and the other cases. So I think from what I could understand, I think that only this person's was actually serotyped. The rest of the cases in the outbreak were mild. And this serotype follows the sylvatic cycle, but unlike the other 4 serotypes which follow the human cycle. And again, the cause of emergence could be some genetic recombination or things like that. And that could, if these serotypes, like new serotypes come in, the problem is that there could be a setback to our tetravalent vaccines. So we need studies, or we need to look at data to see whether there are additional sylvatic dengue. So also important for us to look at the viral host interactions. because this not only just the genotypes, we have also the subtypes coming up, or the clades. For example, if you look at some in Nicaragua, what happened is there was a replacement of the circulating Dengue. This is the clade that is replaced by this clade. And what happened is that because of that, there were differences in the severity of dengue. So we need to look at this evolution, and also the intra-host genetic diversity, and these things also will help us to make inferences. So that's a little bit about the viral surveillance that is required. And then all of us know very much about clinical surveillance, and that is the importance of that. But some points I'd like to make is that when we look at dengue, there are some things like what are the diagnostic challenges. And then the most important thing that we want is to bring down the mortality, because the government is also looking for a zero dengue death initiative. And so we need to look at why people die of dengue. So these death audits at the individual level are very important. And most often there are many fever deaths as well. And the minimum that we could do is at least if we could get some blood samples of these patients, if not the pathological autopsy, if there are some blood samples of these patients, if they have some protocol where we store these samples and analyze it further, definitely we could get a better idea of these deaths. And then what is the actual case fatality? We really can't make a real estimate of the actual case fatality. What we have is the reported deaths. And so that is very important. And in order to reduce the deaths, we need to have some studies or surveillance, and what are the markers of disease severity. Because we have individual studies, but at the state level or at the national level, representative studies would be good. And we could look at the host characteristics or the viral characteristics or the biochemical parameters. And also, we could use ultrasound as a point of care ultrasound. Could be some of the indicators or markers, the ultrasound could be used to predict severe dengue. So, and then what proportion is actually severe dengue? What proportion is secondary dengue? Do we have data or this correct figures of this? Actually, we need to have, because are we actually testing every dengue patient to see whether it is a primary dengue or secondary? At least can we have a sample of patients tested? So we say that 5% of could be severe dengue, but what is the real figure from our state or from the national level? And then we have national and state protocols. So what is the adherence to the protocol? So does it have a role in reducing mortality? So things like that are some of things we can look at. So I think all of us know about this viremia phase. And why I'm showing you this figure is all of us just to remind us about that we have the three phases: the febrile phase, the critical phase, and recovery phase. On average, you could like say 3 days of the febrile phase, 2 to 3 days of the critical phase. So here, this is the phase where we want to pick up the cases early. That's the febrile phase. So usually early, we do not do any kind of testing in the first 3 days of any fever. So we are likely to miss a lot of cases, but then we cannot bring that up as a widespread strategy. So we need to come up with some, like usually what we do is the IG ELISA, and those results are actually maybe a little late sometimes. So a very important need is that we need some affordable, easy to perform acute phase dengue diagnostics. Of course, we have the NS1 and we have those cards and all, which need to be validated. And we had a small study which we tried to validate the cards, and that was actually, the results were good. I have not put it here, but we could use it at the field level for dengue diagnostics. But then what about the cost? Then we must come up with newer methods where we can have better acute dengue phase diagnostics. That as a library gland, I just put in between. So another important challenge with regard to dengue diagnosis, the cross reaction with other flaviviruses, especially in Kerala. And, we have the Zika also. And so if there are other flaviviruses in circulation, we may have to validate, like we have to look at the PRND to find the plaque reduction utilization test to determine the etiology of the flavivirus, which was usually positive 6 months post-infection. And that is perhaps useful for us in the seroprevalence checks. So what we could do is, like you can, when you're doing the serosurveys, we can combine the serosurveys for multiple diseases together. And I think it's almost 15 minutes now. Now I'll just try to go through the rest of the presentation quickly. Now another data which shows that there is a need for focusing on mortality reduction. We actually did a cost analysis, and we found that the cost of fatalities, we had the cost of treatment and cost of prevention, that the cost of fatalities is the highest among the cost. So this is what you know about the antibody dependent enhancement. When there is dengue virus 1 coming in, you have the neutralizing antibodies and the non-neutralizing antibodies. And the complex is formed with the neutralizing antibodies, and the non-neutralizing antibodies remain there. And suppose you have another infection with dengue 2, now this combines with the non-neutralizing antibodies and facilitates its entry into the cell. So which means that secondary infection is going to be more dangerous. But we could look at whether it is actually secondary by looking at the IgM-IgG ratio. If it's more than 4, it indicates primary infection. This is a simple way of looking at it. So we need to look at what are the risk factors. These are some of the already established risk factors you know of. And it's also the serotype is important. I think I'll skip this. And then pregnancy, I have a specific interest in pregnant women. What I suggest is there needs to be surveillance about fever, all febrile illness in pregnancy. There has to be a mechanism where at least we test the subsample of fevers in pregnancy to know the etiology of the illness, because it is very relevant. And in this was again from my PhD work, and what we found that overweight dengue patients had higher risk of preterm deliveries and an adverse outcome score of 3 and more. And dengue was independently a determinant of delivery complications, newborn problems, and newborn admissions. So we are talking about this ultrasound and point of care ultrasound, which would these are some of the pointers, like in the ultrasound, the gallbladder wall thickening, pericholecystic fluid, hepatomegaly, splenomegaly, pleural effusions, the morphology of the gallbladder wall thickening. Then you can measure the inferior vena cava diameter if you have a point of care ultrasound, and the inferior vena cava collapsibility index. So these could be some of the markers for predicting dengue. This is another small study we did for finding out the risk factors of mortality. Sample size was very less, but then we found that altered sensorium, hypertension, were independent risk factors of mortality. So what we see is with all the communicable disease, we know that those having non-communicable disease, diabetes and hypertension, they are at risk of having increased severity of the disease. So we have the burden of NCD, increasing the burden of. So this is the state protocol. All of us must have seen this, and adherence to the state protocol in the surveillance. Perhaps we could have looked at whether what proportion of the medical officers are actually adhering to the protocol. So that's about the clinical surveillance. I look at the entomological surveillance. We do entomological surveillance currently mostly on the immature forms of dengue that look at the larvae. But we generally now don't look at the adults. But what is recently said that is we must look at the pupal indices as well, because the larvae, high percentage of that may die out and they do not become the adult. Whereas the pupa are much more closer to the adult. And adult vector density also could be looked at. You can look at what is the virus or the presence of virus in the vectors, the serotype of the virus in the vector. So we have the National Center for Vector-Borne Disease. They do actually look at it when there are outbreaks, but what in between outbreaks? So are we looking at having a year-long entomological surveillance? So that is the point that I'd like to stress upon, that we need a continuous ED surveillance throughout the year. And then we also need to look at the control measures that we adopt, whether the insecticides that we use are getting resistance. We need to have a surveillance of the insecticide resistance. So this is all what we know, and these are the indices that we use. The pupil index is something that we need to actually, which is now advocated, number of pupae by the number of houses inspected into 100. So for the adult, we can have resting collections, and it is actually landing collections are advocated. We don't, ethical reasons, we don't advocate the biting of people, and so you can express it in manner or density. And in places where the density is low, we can use oviposition traps as well. So it is surveillance predominantly of immatures. The oviposition traps we use when we have a low population density. Larval surveys are unproductive. It is when the Brito is less than 5. So this is what we generally talk about the interpretation, but these are all actually derived from yellow fever surveillance. And there are studies which show that these are not really correlated with the dengue. And just to show you the fact that this is one small study again that we did in Trivandrum. And we can see that among the water holding containers, the highest is the plastic container. But if you look at the ED's positivity, it is like among we have very few tires, but the most productive of containers was tires. So it is good for us to look at something called as this breeding preference ratio. So what is breeding preference ratio? Is actually you have the different types of containers here, and of the containers you find a percentage of each type of container, that is X percentage. And then you have those containers with larvae. Of the total the positive containers with larvae, you find the percentage. And then breeding preference ratio is just Y by X. So if in that study, if we actually look at, we found that the tire at the highest breeding preference ratio. So in terms of the numbers, some of the containers may be less, but they may be very productive. So what is the relevance of finding this, or looking at this breeding preference ratio in surveillance? We can actually target our IEC more in that direction. So we can say, I don't know how many of us have tried to actually put out the water from a tire. It is really difficult to put out the water. It forms a small microenvironment. And this ED is very fond of this black, dark, the dark corners, like the dark places, cool, shady places. And it is very difficult to get the water out of the tire unless you put a hole in it. So such type of breeding places we need to identify. Also important for us to identify which is the abundant species of EDs. You can find from the larvae as well as the adult vectors. You can find whether it is Aedes aegypti or Albopictus. In our small study, we found that Albopictus was more, because you know about, if we have time, we will discuss about it in the discussion. You know that this there's a difference in the species with regard to the vectorial capacity. And the Aedes albopictus generally has got a broader host range compared to Aedes aegypti. And Aedes aegypti is very anthropophilic, and you can see that this is a study which actually, this is a systematic review of the feeding habits of the different types of Aedes mosquitoes. And this is I think I'll show you in the discussion later. I think this is the first graph is that of Aedes aegypti, and you can see that it is feeding mostly on human beings. And in our study also, what we got was Aedes albopictus was the most abundant, but then Aedes albopictus was distributed equally in rural and urban areas, whereas the distribution of Aedes aegypti was significantly higher in urban areas. Okay, and again, there was a difference in the positivity of containers during the monsoon and pre-monsoon period. Significantly lesser positivity was found for containers during the monsoon period than compared to the pre-monsoon period. So this is a study from Delhi, and this is to tell us that the interventions and surveillance, it's not important for us to do only during the transmission season, but it's during the non-transmission season also it's very important. So they divided the clusters into intervention and study groups. And what they found is that in the intervention clusters, actually they did intervention during the non-transmission season as well. And as a result of that, they did not get any dengue cases. One case of NS1 positivity was observed in the study group, and they're telling that it is effective. So the point is that we have to be vigilant throughout, and all the surveillance and interventions has to be throughout the year. This is about the, I think I skipped this, that we said that we need to find the insecticide surveillance. I also say it is important for us to have a surveillance on the control measures, whether it's effective at the local level or not. And when you have a newly introduced measure, now for example, there is some signs of this manipulation of this mosquito microbiota in this use of this Wolbachia infected mosquitoes, etc. Whenever we have some new control measure that is introduced, we need to have surveillance to find out how it is effective. So, and then it is also important for us to have a surveillance of the entomological determinants, the geography of the place, the climatic factors, of which I've just put the temperature there. Then we have to look at other climatic factors as well, because these mosquitoes are basically poikilotherms, and the body temperature will vary based on the outside surrounding temperature, and has an influence on a number of factors related to the vector density and the amount of blood meal that is taken, the number of meals that is taken, a lot of things. And with a 2-degree rise in temperature, is said, extrinsic incubation period of the dengue virus is shortened, a lot of things can happen. And so this is looking at if you look at the modeling methods this is a review of dengue outbreak prediction models. Most of it, 70% of it has used climate variables only. But as of now, we do not have any of these climate variables measured in our routine surveillance. So which means with the routine surveillance, we may not be able to arrive at predictions. And this is the climate and other variables, like the other variables like the demography, then the vector. But climate only has been used in several studies to predict dengue. So we need to have a collaboration with the Virological department. We need to add some climate-related variables in our surveillance. So regarding vaccine, is there a ray of hope? I've talked about the dengue vaccine. I think because of shortage of time, I will just say what are some of the research needs, like we need to look at whether we can lower the number of doses. As of now, we need to be 3 doses, because when you try to scale up the program, this may be challenging. And we need to find out what is the epidemiological threshold at which we can introduce the vaccine. At what level it would be cost effective for us to introduce the vaccine. And as a summary, what I'd like to say is, well, we have just taken you through what are the different kinds of surveillance, and as of now, what is being done, and what are the things that we could strengthen in the different types of surveillance. And the point is that the surveillance system has always signed in such a way that we are able to predict and prepare for epidemics rather than just do it as a firefighting exercise. And surveillance and reporting gets strengthened when we usually see an outbreak. So it has to be for prevention rather than control. And I never say that we have to leave it all to the health service or the department to which is taking care of the people to give us the data. I think academicians have got a very important role to play to support the routine surveillance mechanism with good quality research and projects, which will add on. That's why I have put in some of the research studies and all which has been done to supplement or to help arrive at information to take action. And it has to be longitudinal. We need to develop something like a dengue cohort and see over the years what happens, the changes. And definitely we need to incorporate the climate-related variables. I don't know how it will happen. It's all easy to say, and it is very difficult when it comes to the implementing part. And so I'm just, it's all suggestions, and we need to discuss how we could actually bring it, or we should model and show, demonstrate how we can actually bring these changes. So let's hope that in the coming years, we will have better surveillance, not only of dengue, but all the communicable disease, and we would be able to effectively control dengue. And who knows, when maybe not, maybe we can dream of a day when we are free of rabies. Sorry, free of dengue. Thank you.
Thank you very much, Dr. Zinia, for the quite elaborate talk, which sort of outlines the different strategies for surveillance, why we need surveillance, and what we could look towards to the future of surveillance. Of course, we have a lot of questions, but I think I will restrict the questions to just a few so that we can close well in time. So the first question is by Sambuddha Bishwas. Is it possible to forecast dengue epidemic in India?
Perhaps it should be possible. I think that's why we need some prediction models. But as I said, generally with the routine surveillance data, because of the underreporting, and even we may need a lot of variables which has to be put into the model. So we may need what is the infection rate or the cause of infection. We need what are the factors. We need to bring in the different other factors which determine, like the climate-related variables, the vector-related variables, the virus-related variables. All these will have to be put into the model. And perhaps it is not that it's not possible, but the problem, what I feel is, I had tried to do some modeling for an attempt to do modeling. What I feel is that as epidemiologists, we are not so well versed with the mathematical models, and we need to collaborate with centers like the IITs or people who are well with infectious disease modeling, and work up so that collaboration doesn't generally come in. So if we make an attempt like that, I think it's possible, because I don't know, there may be studies that predict. But how does it, we need to validate those also. How those prediction models actually, are they correct? What is the validity of those models? Are they really predicting? So it could be like you have a model and then you use the model to predict and then see what happens and see what is the validity. So that is also important. It's not that it's not possible, but most of us are often remain within the comfort of our boundaries. We don't, there's no need actually, like it is only out of your interest that you go and collaborate. Otherwise, the government should have a commission research to do that. And as academicians, I think we must go and talk to the policymakers, tell them that is important and try to find out some funding for that and then try to do it. It's possible.
Right.
I hope it can.
Thank you. Thank you very much. So of the many questions, I'm probably selecting the ones. The one is, do dengue serotypes or variants vary significantly from year to year, for example, from 2014 to 2015? And the attached second question is, could a dengue drug which works well against the current dominant dengue variant prove ineffective next year when the dominant variant is different? So
I don't know what the person who asked the question meant by the dengue drug.
Right.
Is it like because we don't have to
we don't have a specific drug
but
yet.
we don't have a specific drug for dengue. So, but the general management principles, whichever is the serotype, remains the same, because our aim is to prevent the mortality, severity and mortality due to dengue. Luckily, we don't have a disability that offers some very long-lasting disability. So our aim would be to prevent severity and mortality. And for that matter, the management would generally be to look at the, to identify plasma leakage early and to do a proper fluid management. And that is where I try to put in the point of this, having this point of care ultrasound. So there were people who even say that you could take the ultrasound to lower levels, not just the taluk level. Because if you have, you could train people to do that and take it to lower levels. Because if you have that, you could identify this plasma leakage early, and probably that would save a lot of lives. Of course, we know that clinical skills are important, but we must make use of technology, and I think we must try to save as many lives as possible. Among the drugs, I don't know if there is a specific drug to the best of my understanding.
Right. Yeah, so there's a question from Richa Bora. Dr. Zinia, what is the scope for molecular diagnostics for dengue? What are the challenges there?
I think Dr. Vinod would be a better person to answer that.
Yeah, so I think we can then take that question off.
No, but definitely, like even if we don't do that on a large scale, I think we need to do at least in a subsample of, and at times when you see there are differences in the presentations, or when you have a clustering which is like beyond what you expect. So think at least that those events must be marked as sentinel events, and the molecular diagnostics needs to be done. But the point is that it is not enough for us to see that and do it, because there needs to be planning. So you have to plan in advance to have some collaboration. Like we can collaborate with Vinod, or we have now the Institute of Advanced Virology, or wherever these facilities are available, there has to be a planned mechanism to do that. And that is why we need, along with the routine surveillance that's going on, there need to be some kind of a system which is ongoing, which looks at all these things. Definitely this molecular diagnostics, very important. We have seen how it is helpful when we had dengue. Sorry, when we had COVID. So also with dengue, we need to establish such
Right. You're absolutely right, because there is increasing evidence which suggests that certain dengue variants are associated with very specific phenotypes. So I think going ahead, that would be a significant addition. So there's a question from, rather comment from Dr. Purushothaman. So cross-reaction is creating problems mostly with Zika, less with Japanese bee and West Nile, because the last two won't cause confusion as the clinical features are different. So unless we do the plaque reduction utilization test, we routinely may be missing Zika cases in this epidemic.
Yeah, unless we act, we may be missing sometimes. But
and that's also probably,
I think generally, but with the cross reaction, this PRNT, we are able to do only in serosurveillance studies. So that's where the role of the clinician is very important. How you distinguish, and then they look at the epidemiology, like the linked cases where the person comes from, and maybe we might make a better diagnosis that way. I think that should answer this question.
Right, and I think that is also where molecular diagnostics could actually make a difference. There's a question from Dr. Sarda Devi. Recently, dengue NS1 antigen positive with a patient was also positive for IgM West Nile ELISA. Do we have to do for PCR or PRNT for confirmation?
I think it's Sharda madam, microbiology madam.
I think so.
So we can have co-infections with the dengue. We have seen co-infections with the same patient having malaria. We've seen dengue and leptospirosis. So also this, it could be false positive. One could be a false positive result. And again, I think that is where our clinical sense would really help us to make between the differential diagnosis, which would you say first? And if there is a difference in management of the case, that would make a big difference. Like if it's West Nile, do we have a difference in management? I don't know, maybe the clinicians would be better off to say that. But in terms of surveillance, when we have two infections, which do we report? So that is another big question, whether you would count it as dengue or whether you would count it as West Nile. So, but I think in the context of looking at that we don't have West Nile so common in our place. So perhaps we would report that as dengue. But for that particular case, I think we need to evaluate that further. I don't know what could be done to like distinguish. But then we can fall if the patient is okay, like the patient's outcome is good. Maybe after 6 months, we can have a follow-up of the patient, and then we would have the IgG antibodies, and then we could do a PRNT to find out whether it was actually dengue or West Nile. Does that answer the question? But we need to follow up. Again, this is another thing that we just, when we have a media report, we do something then and we forget it. But this follow-up is very important, at least as academicians, whoever has dealt with that particular case should follow up the case. And at that time, the government may not be interested. It is our responsibility to take that information back to the government and tell them what it is, because it is important. Does that answer my question? I don't know if
Right. So I think that that concludes the major questions. Thank you very much for the very elaborate talk, and thank you very much for addressing.
I think I was a little out of focus, or I said a lot of things.
No, you did quite some elaborate
because
description.
I would wanted to put in some of the small experiences also. If anybody is interested, maybe they can further contact if you would like to do so. There are so many things that can be done in dengue.
Right.
So I think what is important for us, if we can build something like a dengue study group, or a group of people interested in dengue, then and work together, I think we will be able to do a lot. Already, I think there are a lot of people who are interested in dengue in our place. So we could work together, form a dengue study group, try to get some funding. It could help the routine surveillance, make it better.
Absolutely. That is, I think, a fantastic idea because I believe also in the Epidemic Watch group, there are a lot of medical students, community medicine professionals, and public health professionals, and also public health students who could also give a thought on contributing to this very relevant disease, at least in the locality around them. So yes, thank you very much. And I think
apologies once again, Vinod sir, because I actually wanted to do a review and try to help you or help contribute to the data that you are trying to build. Maybe the coming days, I work with Dr. Sri to volunteer to do that. When work it. And if there's anybody else also who's willing to help, maybe we will contact. Thank you very much for the opportunity.
Thank you very much. Have a good evening.
Good night.
Bye.